Hey guys, this is Joe. I was there teaching you depression a few weeks ago. Sorry about the delay. I've been having some computer troubles getting this up and recorded. So here we go. This is attempt number 5. So the objectives: become familiar with common drugs of abuse, recognize common effects, identify appropriate treatments. Statistics: this is a major health problem and it's growing every year. You can see alcohol, tobacco, and other drugs, nation's #1 health problem. We have approximately 15 billion current illicit drug users, and it costs almost $500 billion a year. So, some terminology before we get started. Psychologic abuse, so compulsive drug-seeking behavior. Drug use for personal satisfaction, so think of something like tobacco and alcohol. Physiologic, so you get actual withdrawal symptoms that produce signs and symptoms opposite of what you seek by use of the drug. And so you need to kind of appreciate the difference between these two. So withdrawal, as manifested by either of the following: the characteristics of withdrawal syndrome for that substance, and these are specified in DSM-5, so the substance or closely related substance is taken to avoid withdrawal symptoms. And then we have addiction, so state of physiologic and psychologic dependence. And then tolerance is a little different, so you don't have dependence, but you have tolerance, so you've increased the number of receptors for the drug, and so it takes more drug to elicit the same effect. So the diagnosis, and this is from the DSM-5, so the substance is taken in larger amounts or over a longer period than intended. There's persistent desire or unsuccessful effort to cut down. A great deal of time is spent in activities necessary to obtain the substance. You have a craving or strong desire or urge for the substance, or there's recurrent use of the substance, resulting in failure to fulfill major role obligations at work, school, or home. So this is straight from the DSM-5, and it's really just kind of going down and saying that you use drugs, they interfere with your personal life, they interfere with your public life, and it's a problem. Continued on down this, you start to recognize that it's a problem, but you don't really care it's a problem, and so I'll let you read these on your own. So drug-related problems, we kind of just went over them, but there's some more. The ones that I want to point out are doctor shopping, so seeking drugs from multiple physicians. Then you have polypharmacy, which is where you get drugs from different pharmacies. You can complain of either ineffective or short-lived therapy, or you can complain aggressively for drugs, or you can request specific drugs. So keep in mind that complaining of ineffective or short-lived therapy, complaining aggressively for drugs, so if you start somebody on opiate and then they develop tolerance, remember tolerance being you've increased the number of receptors, so the same amount of drug does not cause the same analgesic effect, then, of course they're going to say that it's ineffective or the therapy doesn't work as well, and they may complain aggressively for drugs if they're in a lot of pain. So let's cover the first drug that we have. Obviously, there's no therapeutic benefit here, but it is one of the largest used substances in the world. So alcohol, there's 8 million alcohol-dependent people in the U.S. There's approximately 500,000 withdrawal episodes of withdrawal severe enough to require treatment. And so everybody can experience minor withdrawal, even just binging on alcohol, every once in a while. So insomnia, tremulousness, anxiety, headache, diaphoresis, palpitations. Some people will say alcohol helps them sleep better. That's actually kind of a lie. So it helps them get to sleep, but they don't achieve the level of sleep necessary to quote-unquote be rested. And then, these symptoms present about 6 hours after ceasing, and they resolve 24 to 48 hours after that. And so you can actually have withdrawal seizures, and hallucinations. And so these are really more for heavy drinkers. So withdrawal seizures 12 to 48 hours after last drink may occur only within 2 hours of abstinence. So these can happen very quickly. Hallucinations take a little while longer to set in. So this is 12 to 24 hours and usually resolve in 24 to 48 hours. And so let's kind of cover some of the treatment options for this. So the first one is disulfiram or antabuse, which you really won't see anymore. I think some places have kind of started taking it off the market. And so what it does, when alcohol is metabolized, it's metabolized by aldehyde dehydrogenase to acetaldehyde. Acetaldehyde is then metabolized further, and it becomes more hydrophilic, so you can pee out the metabolite. What this does is it inhibits aldehyde dehydrogenase, and so you get increased levels of acetaldehyde, and acetaldehyde it just hangs around because you have no aldehyde dehydrogenase to break it down, and all of a sudden you get this flushing, you get sick. This is what causes that tachycardia, that hypotension, that nausea and vomiting. This is the hangover, so to speak. So in summary, alcohol gets converted to acetaldehyde in the body. Aldehyde dehydrogenase takes acetaldehyde and converts it into something more hydrophilic, something that can be peed out. By blocking acetaldehyde, you increase the level of aldehyde levels. By blocking aldehyde dehydrogenase, you increase the levels of acetaldehyde, and all of a sudden you have symptoms of a hangover. So this is really good for highly motivated, supervised, uncomplicated patients. What I mean by that is somebody you are sure isn't going to have a drop of alcohol, because a drop of alcohol is going to be enough to make them sick. You tell patients to even avoid mouthwash with alcohol in it. And here's the dosing. Contraindications are really those with cirrhosis and the poorly compliant, because it's metabolized by the liver, so you should avoid this in cirrhotic patients. But it is pregnancy category C. And so before starting this, they need to be abstinent from the drug or abstinent from alcohol for at least 12 hours, or they have to have a negative blood alcohol level. And then you want to confirm that there's no allergy to disulfiram and that they're not taking Flagyl, because Flagyl has a ring similar to disulfiram. It has a disulfiram ring, and so this disulfiram ring on Flagyl can actually cause what antabuse causes, and so people who take Flagyl cannot drink. Our next one is naltrexone. So naltrexone is an antagonist at the mu receptor, which blocks the reinforcing properties of alcohol. Alcohol has an analgesic effect as well, but it also stimulates the pleasure centers of the brain. And so if you block the mu receptors, you get rid of that pleasure. And so short term, it's good. It's been shown to reduce heavy drinking days. Long-term benefit may be mixed. They haven't really shown any true long-term benefit yet. Theoretically, the benefit is with maintaining abstinence, but the combined study showed best results when used in combination with counseling. So the dose is 50 milligrams a day. You can increase it to 100 milligrams a day, or there's a long-acting intramuscular injection that's given once a month. And so adverse effects, they actually increase with higher doses, and so nausea, vomiting, headache, anxiety. Again, kind of remember you're blocking those opioid receptors, so you're blocking your body's natural opiates, the endorphins, from binding as well. Hepatotoxicity can be seen with doses higher than 100 milligrams. It's best used if they're already abstinent from alcohol, but you can use this at any time. And the contraindication, remember, it blocks the opioid receptors, the mu receptors, and so the contraindications: prior opioid use within 7 to 10 days, hepatitis, or liver failure, and it's pregnancy category C. And then we have a camprostate, which is an N-methyl diaspartate receptor antagonist and a GABA-A receptor agonist. So remember, these kind of work in opposition of each other. So you're blocking the excitation signal, and you are stimulating the kind of the relaxation signal. And so short and long-term studies show increased total abstinence. Best benefit in patients with a goal of complete abstinence as opposed to reduced heavy drinking days. You can use this at any time. It does take about 5 to 8 days to start working. There's weight-based dosing that you can see right there. Side effects are similar to the other ones, but this one is not metabolized by the liver, so you don't worry about hepatotoxicity. It's eliminated by the kidneys, though, so you do just want to be sure that the renal function's good. It's used in patients with alcohol use disorders, but it can also be used in patients with opioid use disorders. And so the last side effect I want to talk about, I know we kind of skipped through the other ones for a second, but delirium tremens. This is severe withdrawal, and part of the reason I waited to bring this up is because obviously the seizures and all that, there's something to go to the hospital, but this is kind of the syndrome. And so delirium tremens is severe withdrawal. You see the hallucinations that we talked about before. You can see the seizures. You'll see disorientation, tachycardia. So all of these things, and it can persist for up to a week. This is a medical emergency. And so risk factors, sustained drinking or previous delirium tremens episodes, age greater than 30, elevated blood alcohol level, longer period since the last drink, and it can have up to a 5% mortality. These symptoms can develop quickly, they can develop slowly. It's difficult to predict, so that's why it's a medical emergency. And so you need to be careful because those seizures that you see, they can develop status epilepticus, which is refractory seizures that start and go for a period of time, and then you have to basically load them with benzodiazepines. And so initially the management is symptom control for that nausea, vomiting, headache, dehydration with IV fluids and nutrition, benzos for the agitation and prevention of the seizures, so diazepam, lorazepam, chlordiazepoxide, and then we'll use banana bags, which are just thiamine, folate, multivitamins, and isotonic solutions. The reason we do that, we want to prevent something called Wernicke's encephalopathy, which is permanent. You really don't see banana bags studied, but you will see patients get thiamine, folate, multivitamins because they haven't been eating, they've been drinking, they're malnourished, and that malnourishment is what causes Wernicke's. And in the hospital, this is a nurse-driven protocol. It's used with the CWAB protocol is what's used, and so nurses really take control of this, and they manage the symptoms based off of what's prescribed. And here are the benzodiazepines we use. Again, I'll let you guys read these. Typically, I say Ativan is used more often. You will see some Librium and some diazepam, but Ativan is what I've seen used quite often. Alright, the next one will be opiates, and that'll be up shortly.